Good evening, everybody. Hope you're doing well. Thank you, Tori, for kicking that off. Hope you guys are doing well and enjoying your Tuesday evening wherever you are at. My name is Nate Lighthizer. I'm a faculty member and dean at the Oklahoma College of Optometry in Tahlequah, Oklahoma. I have been using ERG since 2009, hard to believe, 16 years, and have been using the RETeval for the last 2 to 3 years in our clinical practice here at the College of Optometry. We'll talk more about that going forward. So it's my pleasure to share the virtual stage with Dr. Bradley Grant. Dr. Grant, go ahead and introduce yourself.
Yeah. Thanks for having us. Dr. Lighthizer and I did a conversation like this a few months ago, so excited to be back and share the stage with the best. My name is Dr. Bradley Grant. I practice primarily in central Illinois. I have a few locations. I'm in private practice and an OD-MD setting, but we also have a few in Wisconsin, all private practice. And we've been RETeval users for right at 2 years now. We've had the device now since June of 2023 and have the all of the offices outfit with the technology. And so really enjoy having that extra piece of functional data that we can offer to our patients. And so excited to talk about it.
Yeah, and I want to challenge all of you on here tonight, to really think about this with an open mind and going, I maybe have heard of ERG when I went to optometry school, whenever that was. ERG has just completely changed over the last 10 to 20 years from being something that was in the research center to now that this handheld technology with the RETeval that you can bring room to room to room. I'm telling you, I've had patients, their eyes just light up when they see this technology, go, wow, my doctor has got the latest and greatest in this technology. And we'll tell you all the bells and whistles of this and all what this does going forward. There's so many different protocols that you can pick and choose in this patient and in that patient, all the different types of patients. So looking forward to talking about the RETeval, the ERG in action. So poll everywhere. I'm going to ask you guys one question. So that's on the next slide. So, grab your phone and scan that QR code. Grab your phone, scan that QR code. That's going to open up my poll everywhere page. And it's going to ask you one question. And again, it's completely anonymous. You don't have to download anything. You don't have to sign up for anything. Again, if it asks you to download something, just hit skip for now. Skip for now. So scan that QR quickly. Got one question on the next slide. Kind of just keeping this very interactive. If you have any questions at all as we go through this, please don't be shy. Please don't be shy. There are no dumb questions at all. You wouldn't believe the things that I thought of the ERG and going, the misconceptions I had, the wrong ideas that I had, and you learn from that. So again, please ask any questions that you have. Scan this QR code, and it's going to ask your first question, completely anonymous. It's just a real quick one here. It's really just a fun question. Do you think testing structure and function in our ocular pathology patients is important, whether it's glaucoma, diabetic retinopathy, macular degeneration, plaquenil, whatever it is, structure and function, is that important? I asked this question to the Virginia Optometric Association. I was lecturing in Virginia on Thursday afternoon, and I asked this question, and 100% of them said, yeah. And look at you guys, 100% of you go, yeah, testing structure and function in our ocular pathology patients is important. We know that you believe that. We believe that. We're all colleagues. We all believe that. Why is that? Because it gives you the best possible picture in whatever condition that you're looking at. Again, whether it's glaucoma, diabetic retinopathy, macular degeneration, or something else. Glaucoma, we want OCT, but you got to have that visual field, structure, function. So I want to challenge you guys, especially when it comes to diabetes and diabetic retinopathy, something all of us see on a day in and day out basis, probably an hour in and an hour out basis, is diabetes and diabetic retinopathy. What are the most common things that you do in diabetes and diabetic retinopathy? Most common ancillary tests, most common things that you do. It's a dilated fundus exam, a DFE, fundus photos, and OCT. When you think of a DFE, fundus photos, and OCT, that is structure, structure, structure. A DFE looks at the structure. A fundus photos is a beautiful structure test, and an OCT is also a beautiful structural test. ERG pairs wonderfully with those. You're not going to hear Dr. Grant or myself say that ERG replaces OCT or ERG replaces fundus photos or replaces your DFE. It doesn't. It goes along with that. Just like an EKG goes with an echocardiogram, goes with an angiography, they go together. And, people are now recognizing this, where 10 years ago, 20 years ago, weren't recognizing the journey to standard of care for functional testing. Those of you that didn't know that, this is huge. For the first time in history, ERG has been added to the American Academy of Ophthalmology's diabetic retinopathy preferred practice pattern guidelines for both diagnosis and disease management. This is a big, big deal. The RETeval is included in 2 Mary Tyler Moore Vision Initiative sponsored clinical trials being conducted by the Diabetic Retinopathy Clinical Research Network. The device was selected for its potential to measure retinal function as this seeks to augment the current guidelines for detection and staging. Things are evolving. OCT wasn't available 25 years ago, or at least in clinical practice. OCT angiography wasn't available 10 years ago, and ERG really wasn't there to be in these clinical guidelines, and now it is because of the testing that we now have. Dr. Grant, your thoughts? This is just a huge, huge deal and a huge win for patients that this is now recognized. We got to have structure and we got to have function with ERG. Dr. Grant, your thoughts on this slide?
Well, I would say two different points here. One on the first, the American Academy of Ophthalmology doesn't put its stamp of approval, if you will, on any device that doesn't have very sound clinical research backed evidence to its necessity, right? And so, the RETeval has over 200 peer-reviewed publications in terms or research clinical trials, and so I think this is just evidence to the fact that the test does what it says that it does, right? It gives us a good predictability for progression in diabetic patients, and then on the second point, the Mary Tyler Moore Vision Initiative sponsored clinical trials, if we look at how we currently stage our diabetic retinopathy, all of it is based on either the DRSS or the ETDRS. Many of you may know this, many of you may not. ETDRS started enrolling patients in the 70s, right? It first was released in the 80s, which probably predates the existence of some of us on the call here, right? And so think about how much just the prevalence of diabetes has changed in the last 40 years. Think about the way that we can assess, as Dr. Lighthizer was talking about, function as well as structure. Again, it's a completely different world than what it was when our current grading systems were invented, if you will. And so I think it's high time that we're including the structure and the function in the assessment and the diagnosis. And so this is exciting stuff.
Yep, exciting, spot on, Dr. Grant. Really, I love the title of this, The Journey to Standard of Care for Functional Testing. And these 2 points really drive that home where this journey has taken us. So structure and function of ocular disease. Again, we've kind of already made this point of there's your wonderful structure. Take some photos. You're not going to remember the level of diabetic retinopathy, exactly where everything was 6 months from now or 12 months from now. Take a photo. Take a beautiful, maybe it's a wide field photo, maybe it's a posterior seg photo like you're looking at here, but take a photo, bill for those photos. Again, wonderful testing. OCT. How many of you have OCTs in your practice? And again, when I poll the audience, I did an OCT lecture in Virginia on Friday afternoon, and 90% of optometrists in the audience, there's about 150 there, had an OCT. It's been fun to see those numbers change over the last 10 years from 30% of ODs to 50% of ODs to 70% of ODs, and now going to close to 90% of ODs having an OCT in their practice. But OCT has evolved as well. We don't use the same OCT in 2025 that we did in 2005 when I entered optometry school. This OCT was the first one that I ever utilized, the Zeiss Stratus OCT time domain, and it was revolutionary. But again, this was 20 years ago technology, and let's not get stuck on 20 years ago technology in ERG. So that has evolved to a more high definition, higher resolution OCT. And again, beautiful structure to be able to see those different layers. You pair this so nicely with ERG structure and function. Again, we've got our macular OCTs as we've talked about. So functional testing.
Nate, do you remember how long it would take to acquire a scan with the Stratus?
Oh man, it took a while. You had the joystick and you had to get through, smaller pupils that didn't handle very well and those lenticular opacities. But wow, we were living large when we had that Stratus OCT, but it took some time, didn't it?
Yeah.
Yeah. It holds a special place in my heart, that Stratus OCT, because I went to school at Pacific University from 05 to 09, and that's all we had. That was the Stratus OCT is what we had. So that's what I trained under. So, all right, functional testing. What are our options? We test function. Visual acuity is subjective, and visual acuity is very tied to the center 2 or 3 degrees of that fundus. We've got contrast sensitivity. Again, that's subjective, and who's really doing contrast sensitivity in their practice? Very few. How about color vision, color contrast testing? That is subjective as well.
Dr. Lighthizer?
Yes.
I don't mean to throw you off. I'm going to take over sharing the slides. Yours keep getting blurry, and we want to make sure we're not missing anything.
Sounds good.
Two different.
So.
Two different. That does look clear to me.
Go.
Let me know. Are you seeing what you're supposed to?
Yep.
Delightful. All right, just let me know when.
Okay, so color contrast, that is also subjective. We keep going here. And visual field. All of you have visual fields in your practice, but again, that truly is subjective. How many of you have done a visual field and then you regretted doing the visual field after you got the results back and you go, what do I do with this? Again, it's standard of care in some conditions such as glaucoma, but it certainly has limitations. Amsler grid, again, also subjective. It's relying on the patient. Are they going to do that? We keep going here with our functional testing. Preferential hyperacuity perimetry. Again, most of us are not going to have that in our practice. That is, again, subjective. And dark adaptation testing. Dark adaptation, the Adapt DX, that is a subjective as well. And that's, kind of went off the market here. And your ERG. This is a great functional test, and it is objective. It is not relying on the response of the patient. If they can look straight ahead and hold their eyes open, that is what relies on the patient. Yes, you need to have reasonable fixation, but you can even move your eyes around a decent amount during the test, and you're still likely going to get reliable results. The patient is not clicking a button. It doesn't rely on them. It is objective functional testing. I want you guys to remember that. It does not rely on the patient. It is objective. Dr. Grant, any questions or any comments on this slide?
Two different. No, not just a great review of all the ways that we utilize standard clinical tests and depend so much on the patient response that sometimes is not perfectly reliable.
And it really drives home that is function important. Look at all these functional tests, but they do have some limitations of being subjective there. So let's go to the next slide.
Two different.
So, what do you think of when you think of electrophysiology? We can just go through this very quickly. You guys, I always make the joke. You guys remember that room in the back at school? It was dark back there, wasn't it? There was no windows in that room. You didn't want to go back there because there would be wires hooked up to you and who knows what kind of places on your body. And, you had all these different things. And my point is electrophysiology. This is a picture I got off the internet. If you go, holy smokes, we're reading minds here, ERGs of 1980, 1990, I will even say 2010. I took over as the chief of our electrodiagnostics clinic in 2010. Electrophysiology in 2025 is different than in 2010. So we used to do tests that you had to dark adapt. You had to sit them in the dark, and they had to sit there for 45 minutes, invasive electrodes, and it's completely different. Now, dilate for every single test, now not necessary in some of the tests. It's completely evolved over the years. So let's keep moving on to electrophysiology. All right, so this is, again, ERG simplified. This is a handheld device, and I have been surprised at how patients love when you can bring a test to them, whether it is a visual field in the headsets, so what you can bring to them, whether it is the ERG. Patients love. I walk in the room in diabetic clinic or glaucoma clinic or whatever it is, and I say, hey, Mrs. Jones, we're going to run the EKG for the back of your eyes. Do you know what an EKG is? And it's amazing how every single patient knows what an EKG is. And I'm like, I've had an EKG, doc. They put the electrodes on my chest. And I said, yes. And that tells you how's the heart functioning, how's the heart firing? Basically, how is your cardiac system working? This is the EKG for the back of your eyes. It's called the ERG, the electroretinogram. And it's going to tell us how's your retina firing, how's your retina functioning, basically how is your retina working. And we're going to pair this with fancy pictures to give us the best clinical picture for how your retina is looking and how it's working as well. And I tell you, patients, their eyes just light up going, wow, my doctor gets it. He's got the best technology and he's going to take care of me. So be accessible, to be able to bring that right to the patient is really great. Easy to integrate. You know, this is going to take you 1 minute in the right eye and 1 minute in the left eye, and maybe an additional minute or two to set this up. You go take it right to the patient, simple to use. Again, we'll go through the different protocols in just a second. And again, the investment 92273 is the CPT code, reimburses on average about $120. Dr. Grant, you know, you're in private practice. I'm in academia. So we run a lot of tests to get a full picture, teach our students, teach our residents, you know, things like that. We still are very clinical. Tell us from a private practice perspective, accessible, affordable, investment-wise, your thoughts.
Right. I would say 2 points that we really can't overstate. One, the portability is huge. I mean, all of us that are in really any clinic, but especially in private practice, space is a premium. And so we have all of our other functional tests or structural tests that we've talked about, or instruments that we've discussed. OCT sometimes takes up a room. Visual field takes up a room. If you have somebody in the visual field room, that room is on lockdown for maybe 15 minutes, right? So how many times in our clinics day to day do we bottleneck at a certain test, and then that slows down everything? And so in our clinics, when we integrated it, we set up a specific laptop that was just a docking station for the RETeval device. And the ERG was the last test that the patient received before the doctor comes in the room. And so it's done in the exam room, in the exam chair. Our technicians come in, they put the electrodes on the underneath the eyelids, administer the test right there in the exam room, and then they bring the device back to the docking station, which is kind of at the, we'll call it the tech island, if you will. And then that sends the report into our electronic health records, and then I'm actually able to then view the report outside the room, but also pull the report up on the screens in the exam room for the patient, so we can review the testing. And so portability is phenomenal, so that we can integrate it along with our other tests without having a logjam. And I would say you also can't overstate the fact that this has a CPT code, right? It has a CPT code, which means it's billable. How many times do we talk about specialty care in optometry that involves out-of-pocket services that are, you know, cash pay, that we have to convince patients of their necessity, that we have to sell a service to a patient, right? I'll use a goofy analogy. I live in CPTville, right? I live in CPTville as an optometrist. That's where I want to be. I might vacation every now and again in non-covered service city, but I'm staying in CPTville. That means it's time tested. That means the FDA has approved it. That means Center for Medicare Services has approved it. We're able to do this testing from a diagnosis and pathology dictated protocol instead of having to sell a service. Again, in a practice management standpoint, I just don't think that can be overstated enough.
I love that analogy, CPTville. That's good stuff.
Yeah. It may be CP2 depending upon where you live, but you know, one of the two. Yeah.
Yep. And this is I'm trying, just as you were talking, I was thinking this is the 5th or 6th different ERG that I've had in 15 years. And again, the only one that is portable, where you can take to the patient, which has just been absolute game changer in our clinic. Let's go on to the next slide. Don't get it to be a win. We kind of already touched on this already. Does the technology do something our other technology doesn't? Objective function. We don't have an objective functional test in our arsenal that we regularly use. You just saw the slide that had a bunch of functional tests that some of you do on every patient, like visual acuity, and some of you do hardly ever, probably like dark adaptometry, but they were all subjective. All subjective. This is giving objective function. So it's doing something our OCT doesn't. Our OCT is objective structure. Our visual field is objective. Our visual field is subjective function. And I was looking at that question. Yes, we're going to go into interpretation here in just a second. So yes, this technology does something our other technology doesn't. It objectively looks at function. Does it provide clinical information that will impact the treatment of our patients? Hopefully you will see that over the next 30 minutes. Can it be incorporated into our office? We've really already touched on that. Patient flow, staff, space, yes, it's handheld, easily incorporated. The number one protocol that we use in our clinic is the diabetic retinopathy assessment protocol, the DR assessment. And it's an undilated test. You have to be non-dilated for that. So it's not like you're waiting for a patient to be dilated. This is before they're dilated. So yes, incorporated into the office. Standard of care leading edge. We really addressed that already. What's the road towards standard of care with the American Academy of Ophthalmology preferred practice patterns? Again, now listing ERG, the RETeval, in their guidelines. Is it patient friendly? Oh man, is it patient friendly and will be profitable and or practice building? Again, Dr. Grant talked about that already. So I think we've kind of already indirectly or very directly touched on most of these points. Dr. Grant, anything to add before we go on to the next slide in our case studies?
No, it sounds like the crowd is itching for some science. So
yep, let's go. So let's go. So the flash ERG, this is a flash of light. It tests the overall retina. And I always say, you guys are looking at your computer screen right now. I'm looking at my computer screen right now. While I'm looking at my computer screen, I can see the floor and the ceiling and the walls over here. So my point is this: if you were doing an ERG where they were looking at a computer screen, that's called a pattern ERG, and that tests more central retinal function. This is different, okay? We're not holding a computer screen in front of them. You're holding a handheld device that flashes lights in their eyes. And when I flash lights in Dr. Grant's eyes, if I flash lights in them, that light's going to go superior, inferior, nasal, temporal, central, mid-peripheral, and peripheral. Flashes of light in the eye go everywhere. They diffusely illuminate. And because this is a flash ERG, it's a test of overall retinal function. How's the retina doing? Overall, from top to bottom, left to right, central, peripheral. Any contraindications for patients with a seizure history? I would call it a relative contraindication. If you absolutely needed the data, if it was life-changing, I would still do that. But if I have somebody that has a known seizure history, especially from strobe lights, flashes of light, probably would not do that. So I'd say it's a relative contraindication, but it still can be done. Again, overall, global test of retinal function. Let's go to the next slide.
Two different.
All right, so visual acuity, center 2 or 3 degrees. Nothing new here. You guys know that. Let's go through these next couple of slides. I'll talk through them as you go through these. OCT, beautiful job of structure of that center part. And then you take a look at the 24-2 pattern ERG. Yeah, that's going to tell you how are we functioning in this kind of center area, but it's subjective. Remember, the visual field is subjective. Pattern ERG, it's objective, but again, it's looking at that center functioning. The full field ERG, everything, top to bottom, left to right, central, mid-peripheral, and peripheral. Overall, how is that retina functioning? And if you guys look at this patient that you can see has got some peripheral hemorrhages, we're blown out enough, we probably can't see the tiny little microaneurysms. What is this patient's likely visual acuity? What is the visual acuity of most of your patients with mild diabetic retinopathy or even moderate diabetic retinopathy or no diabetic retinopathy? The answer is it's usually 20/20. Visual acuity is not a great indicator of how your diabetic patient is functioning. It's the center 2 to 3 degrees. We've got to get this data. Overall, how's the retina working? All right. Yep, next slide. And we've talked at the different protocols. This is beautiful to look at the different protocols, 92273, whether you do the diabetic retinopathy assessment protocol. That's my number 1 protocol. My number 2 is the photopic negative response, which is the one on the right that tests ganglion cell function. How many of you do ganglion cell structure in your OCT? I bet the vast majority of you get ganglion cell structure on your OCT. So you're looking at the structure of the ganglion cells. If you want to look at the function of the ganglion cells, go to that photopic negative response. That's my number 2 protocol. And my number 3 protocol is the one in the middle. It's my Flickr 16 or Flickr 32. I want to know how the retina is functioning. I'm not doing it because of diabetes, which is my number 1 protocol, but I want all these other retinopathies. I want to know how's the retina functioning. That's my number 3 protocol. The beauty of this handheld device is it takes some of the, which protocol do I have to design this or move the waveforms here? You choose your diabetic retinopathy protocol in a diabetic patient. You choose your photopic negative response in a glaucoma patient or other optic neuropathy, or your flicker protocol in any other retinopathies. Dr. Grant, anything to add for the protocols?
Not necessarily. I would just say that, it's all giving you valuable information. So let's say that you get a flicker 16 on a diabetic patient, you're still going to have useful information in terms of latency and amplitude as far as evaluating the test. So, maybe you rerun it in a month or so on a different protocol. But we have automatic protocols set up with our office to where individuals with diabetes are automatically receiving this test. We have, a lot of the diagnoses that you see listed under those various different protocols. We actually have that set up to where our technicians know,
yep,
if they have that diagnosis in the chart, they're getting the test done before they see the doctor. But I'm going to dive into the PHNR a little bit later on a case. And so that's probably my favorite one. If I had to choose, I don't know if we're picking favorites, but I think that's my favorite.
Yep. Cool. All right. Next slide. Let's finally go into interpretation. And you take a look at this and you go, okay, all right, Nate, I got lines going everywhere. Why are there lines? Just give me a picture. I want to, it's okay. Like this, don't overthink this. Like none of us are cardiac specialists, but most of us recognize that is a EKG waveform there. Okay. And that looks reasonably good. You've got some spikes there and they look reasonably good. And the timing looks very good. Okay. That's normal. And most of you, though, even though you're not cardiac specialists, could recognize that this, if we go to the next one, two different. And that is abnormal. My point is this. You guys aren't cardiac specialists, but you could recognize that, go back one, that is a flatlined EKG, and the one before that looked relatively normal. So here's my point in this. The ERG is the exact same thing. If you go back to the printout, I want the normal one up there. You can't know what abnormal is until you know what normal is. You can't know what abnormal is until you know what normal is. So let's go through this printout, okay? On the left side, notice we have the right eye and we have the left eye. This is that flicker 16 protocol, okay, for retinopathies. Not diabetics, but you get a lot of information in your diabetic retinopathy protocol here. You just don't get your DR score, your diabetic retinopathy score. So let's look at the bottom one, bottom left and bottom right. I'm looking at these lines, these waveforms here, and I'm looking at the height of the peaks and the speed of those peaks. You want your ERGs. Thanks, Ryan. I appreciate that, buddy. You want your ERGs just like you want your athletes, strong and quick. Strong and quick. You want your athletes strong and quick. You want your ERGs strong and quick. The strength of the response is the height of these peaks. Okay, it's the height of these peaks here. Look at that bottom left, bottom right. And the speed of the response is how quickly those peaks are happening. If you look at the bottom left, there's actually a little kind of a cheat box there. Look at that little rectangular box. It is saying that's where your first peak should land. And if it's lower than that, if the peak is below that box, it is low. And if that first peak is behind or to the right of that box, it is slow. I don't want my ERGs low or slow. Again, I want them strong, which would be high, and quick. Okay, strong and quick. That is the interpretation of that waveform. There's the right eye and then the left eye. And then again, that's great, but give me numbers. Give me numbers. I want to have some numbers. You guys look at OCTs and you look at the retinal nerve fiber layer and all the quadrant analysis and all those numbers, okay? So we've got the waveform, the raw data there on the bottom, but just above that, highlighted in green, the waveform implicit time in milliseconds and the waveform amplitude in microvolts, okay? Let's start with the implicit time. Think of the implicit time as the 100-yard dash. If you are in a 100-yard dash, do you want a big number or do you want a small number? And the answer is in a 100-yard dash, you want a small number. So I look at the percentage here, and I want that percentage to be smaller. 10% is quicker than 90%. Okay, the smaller the percentage, the better for the implicit time. So that's the implicit time. The amplitude is a weightlifting competition. If you enter a weightlifting competition, you want a small number or a big number. You want a big number in a weightlifting competition. So unlike the implicit time, where a small percentage is better, for the amplitude, a bigger percentage is better. So I want a bigger percentage for the amplitude, okay? You guys are all very familiar with standard deviations, and green is usually between 5% and 95%. 2 standard deviations in either way, that's going to be in your green. It highlights that just like other tests that we have. Is it in the green, the middle 90%, or is it deviated out to one side or the other there? So that is how you interpret these ERGs. Look at the waveforms there, but I also look at the numbers there, those percentages, okay? Let's go to the abnormal one. So there's normal, and then again, there's our EKG example. There is abnormal, and take a look at this ERG. It is not only low, but it's also slow. It is low and slow. Those peaks are landing below and behind where they should be. And again, if you verify that with the numbers, notice our time. Time in the right eye, time in the left eye, where a low percentage is better. We are about as slow as we can get at 100% and 100%. And the strength, where a high percentage is better, we're again about as weak as we can get at 0% and at 0%. What does this mean? This retina is struggling. This retina is not responding to a flash of light over a minute in a functional, healthy way. This retina is likely ischemic or on the way to ischemia. This retina is struggling, and we need to pay attention to this. So again, what's the minimum VA required for this to provide valid results? That's the beauty of this, is this doesn't rely on visual acuity. This is not a pattern test where they have to be able to see the pattern and fixate. You could do this in a 2015 patient, and you could do this in a count fingers patient. This is not tied to visual acuity whatsoever. So, Dr. Grant, anything to add on interpretations of these ERGs?
So I would just double down and say I describe it just like you do to my patients. I say we're going to test the speed and strength of the response of the retina and break it down just like that. One way I like to think about it, as we're used to some anatomical tests, as we think about that, an increase in latency, a high number in terms of how long it takes for the retina to respond, indicates stress. Think about if you do fundus autofluorescence for your fundus imaging, right? We're used to thinking about the presence of lipofuscin indicating retinal stress, not indicating retinal death. Think about it like that, right? If we have a high latency, right? The numbers are bigger than we want them to be. The response is much slower than we want it to be. That's retinal stress. That's lipofuscin. That's on the way to bad things.
Yep. All right. So now I think that was our last interpretation. Let's add one piece to this. Here's the number one protocol that we do, which is the diabetic retinopathy assessment protocol. So when you fire this device up, you enter in the patient's information, date of birth, and you select your protocol. Okay, I've got a diabetic patient. We're going to do the DR assessment, the number one protocol that we utilize, and it's the DR assessment. And we've already went through the interpretation. Right in the middle, you can see those waveforms, the qualitative waveforms, right eye and left eye. And you can see where those peaks they should land. Looks pretty good, but let's verify with the numbers, the time and the strength in the right eye and the time and the strength in the left eye, okay? And then overall, it gives you a number, a DR score. This DR score is just like your golf game. The lower the number, the better. The lower the number, the better. Clinically, here's how I interpret it. Dr. Grant may do it a little bit differently, but clinically, this is what I base it on. If it's in the teens, I consider it very normal. Teens is a good number in the normal. If it's between 20 and 23, it's low normal. Still in the normal range. It's low normal, maybe borderline, but that's where I consider that. And then 23.5 and above is abnormal. 23.5 and above is abnormal, and 26 and above is very abnormal. And when your patient has an abnormal EKG, they are more likely to progress, more likely to have a heart attack, more likely to have major heart issues that are progressive. And when your patient has an abnormal ERG, what does that mean? It means they are more likely to progress over a certain time frame.
if we would put actual numbers to that based on what the clinical studies show, if you have the existence of both severe non-proliferative diabetic retinopathy and a DR score over 23.5, that would mean you have a 68% chance of progressing to needing retinal intervention in the next 3 years, right? And so, can round up, say about 2 out of 3 of those individuals in the clinical study, when they had both existing severe non-proliferative as well as a high DR score, 68% progressed to needing retinal intervention. What's even more, I think, interesting about that particular study is that when we look at just structure and we don't have the piece of information about the DR score, we don't have function. In that same study, individuals who had not severe non-proliferative diabetic retinopathy, right, had maybe mild, just microaneurysms, had maybe just a few scattered dot blot hemes, but had a higher than 23.5 DR score, 20% of those individuals, 1 out of 5, actually progressed to needing retinal intervention. So if we are not looking at both structure and function, we're potentially missing significant information on 1 out of 5 patients. That's significant.
Yep. And it puts us in the best position to put our patients in the best position with the best education, the best recommendations, closer follow-up. Every touch point is important. We go to our doctor, we go to the dentist, you take a little bit better care in that time around that appointment because you're reminded of that. And I think that's so very important. Now, if you look at this normal one, right eye and left eye, if you just look at the raw data right in the middle, which eye, right eye or left eye, qualitatively looks a little bit better? Right eye or left eye? If you look at those peaks, which one looks a little bit better? The answer is the right eye does. Doesn't the right eye peaks look a little bit bigger versus the left eye? And again, just to make the point, prove it with the numbers. Look at the strength, the microvolts right there. And the right eye, we're right at about 50%. Remember, the bigger the number, the better. And where's the left eye at? About 14% and 12%. Still in the normal range, but low normal. So just matching qualitatively with what we see quantitatively as well. So this is very, very normal. Let's show the abnormal DR assessment. You take a look at the abnormal one and you take a look now, immediately 24.8. 24.8, this patient is more likely to progress, as Dr. Grant said, and you take a look at the waveforms. My question for you is this more low or is this more slow? Is this more low or is this more slow? What's the answer? Two different. This is more slow. Those peaks are behind where they're landing, and you take a look at the times. So you want a small percentage for the times in milliseconds, the implicit time. The smaller the percentage, the better, and we are right at 100% right eye and left eye. The strength is not terrible. Strength is not bad. But Dr. Grant, you would say we're seeing some cellular stress here, aren't we, in this particular patient? This retina is struggling, but still salvageable if we can get this under control.
Yeah. There was a question that just came across the chat. Do we care about the pupil? That very bottom section is actually measuring the pupil diameter in photopic and scotopic instances. And if any of you, when you were in school or like me, we were always taught to document, is there neovascularization of the disc? Is there neovascularization of the iris? Is there neovascularization anywhere, right? And when we're looking at diabetic patients. And the reason for that is because we know if there's significant enough ischemia, then we're going to start to see what we call an attenuation or a smaller amount of change in scotopic and photopic situations with the pupil. And so that's part of what creates this DR score, is it's looking at retinal function as well as pupil function to see if that is compromised as well. And so, yeah, it matters greatly. That's why this particular protocol is done undilated, so that piece of information can be included in the score.
Yep, it's got to be done undilated. All right, I think we are done with our interpretation here. Yep, we've talked about all of this. We are detecting changes earlier, predicting, follow-up, and let's talk on a case here. So case number one is a case that I saw, a diabetic patient in our diabetic clinic, 33-year-old Native American female, lost her glasses about a year ago. no change in vision. You can see her, took a screenshot right out of our EHR, and you can see we're right at 20/20 in both eyes. Doesn't know our last blood sugar reading. Last A1C was 10.0. So we are certainly a little bit uncontrolled in this particular patient. But again, we're doing 20/20 visual acuity pretty good at this point. So let's go to the next slide. Back of the right eye. Okay, back of the right eye. If we go back, that was a year ago, and now that's what we are today. So you can see we've got a little hemorrhage on the nasal side in the right eye. Again, nothing significant, nothing super severe, but we've got mild vascular changes. There's the left eye. Again, left eye, and the change over the course of the last year. I think I have 2 photos of the left eye in this one. There we go. Okay. Again, we don't have any severe retinopathy at this point. OCT looks, pretty good. OCT matches our 20/20 visual acuity. But again, this is just one side of our structure function. So, what level of retinopathy? When would you see this patient back? If you go back to the fundus photos and you go back to the OCT, if this was your patient tomorrow, visual acuity is 20/20. We just had a couple of blots here and there, a couple of small microaneurysms. OCTs look perfect. There's no macular edema, no NVE, NVI, NVD. I think most of us would say we're going to see that patient back in 6 to 12 months, if not 12 months, that's when we're going to see that patient back. But that's not the entire picture. So let's take a look at our next slide. And you look at this patient's ERG. And again, the DR assessment. I have a protocol that I can choose. I'm doing a diabetic. I know that I'm going to do my DR assessment protocol. And right away, boom, I get that number, 24.4. We have structural changes, albeit they're probably not severe, but now we have functional issues as well, 24.4. And that's outside normal limits. And you dive a little bit deeper. And remember, this protocol is dependent on the strength and the speed of the response and the age of the patient and the pupillary response. That DR score, 24.4, from the strength, the speed, the pupillary response, and the age of the patient. So we're outside normal limits. We look at the waveforms, decently strong response. I can, just look at those waveforms and going, all right, those peaks are decently good there. But notice the speed. The speed is lacking. We're taking, we're very slow in the 100-yard dash. We're taking last in the 100-yard dash here. Again, this isn't the worst response I've ever seen, but this retina it's struggling a little bit. It's under some stress. And again, I believe an ERG should be done for all patients that have any structural change, uncontrolled vision changes, or the longer that they've had diabetes. If you see any vascular changes at all, you've got structural issues, and we should see how the retina is functioning as well. So we had an abnormal DR score. And again, as Dr. Grant said, in this patient that has non-severe retinopathy, it's not severe retinopathy, but we have an abnormal ERG, still about a 20% chance that this patient will progress. We need to follow this patient more closely, in my opinion. Instead of a year, maybe it's 6 months. If it was 6 months, maybe it's 4 months. Consider nutritional supplementation. Maybe you consider an OCT angiogram now with this. Lots of different, what level of retinopathy, when would you see this patient back? We talked about that already. And we followed this patient more closely, educated her on the importance of this. Let's repeat this in 4 months. We started this patient on a nutritional supplement, talked diet, exercise. And again, just the complete picture. Without this, we said, it's mild NPDR. Control your blood pressure, control your blood sugar, Mrs. Jones, and I'll see you back in a year. Again, and maybe that's fine for some, but for our patients, they deserve better than that, to give them a better recommendation. And we've now got more data here to give you a more complete picture. So what's been fun is this. Functional data, you can see improvement, particularly data. If we go back a slide, we're showing delayed. We're showing stress here, as we've talked about already. And okay, this patient lowered her A1C from 10 down into the 8s, and she dieted, and she had some exercise programs, and she took nutritional supplementation. Let's go ahead a few slides here. And over the course of the next year, this was her ERG. She went from 24.4 to 21.0, and notice the times are improving. Now, they didn't go from 96% down to 4%, and winning the 100-yard dash, but we're moving in the right direction. And Dr. Grant, this has been a huge win for our clinic, a morale booster for our patients. I have patients come in going, all right, doc, I can't wait to see what my number is today, that they're getting their ERG once a year or every 6 months, and they want to know what their score is. I've been working hard, doc, and it's hard. We all like our candy bar. We all like our large Dr. Pepper or whatever our little vice is. But this is helping move the needle in the right direction. This patient was absolutely thrilled and so proud of herself that she got improvement on her ERG, and I was darn proud of her as well. Dr. Grant, your thoughts?
Right. I completely agree. I think it just improves the quality of the conversations that we have with the patients. It improves it. And that 1 out of 5, that 20%, prior to having functional testing, we don't know who that 1 out of 5 is. And I don't have study information to back it up, but I firmly believe that when we have better diagnostic capability, earlier identifying of stress in the retina, and able to have more productive, more meaningful conversations with patients, I truly believe that helps our outcomes. I believe it helps patient compliance. I believe it just helps to drive home the point of when they're doing okay, to continue what they're doing, but also when they're not doing okay, that some things need to change. So I think it ultimately helps us take better care of our patients. And, ultimately that's what we're here for.
And why EKG is such a strong part of a cardiac workup. Do cardiologists believe in EKGs? The answer is absolutely they do. Why is it taking so long for ERGs? Well, the technology's advanced now. It's now in the American Academy of Ophthalmology preferred practice pattern. So, greater than 200 studies out there. So, yeah, we're lagging a little bit behind EKG, but it is getting there, and the road to standard of care is finally, we're blazing down that road. So there's a tremendous value in ERG. I think we have like 10 minutes left. Let's make sure we get to your case, Dr. Grant, before we can answer a bunch of these great questions.
Absolutely. So I'm going to switch gears just a little bit, and I'm going to focus on the PH&R protocol, which is what we use in our clinic to help us on the differentiation side when we're looking at glaucoma suspects, optic nerve pathology. I would say it's most useful for me whenever I'm on the fence of those individuals of treat or not to treat, right? Ocular hypertensives, am I seeing some stress in that ganglion cell response? So this patient, 51-year-old white female, not a significant systemic history. She does have anxiety disorder. We'll kind of talk about that a little bit, but systemic medications, Ativan, melatonin, we'll go to the next slide. Ocular history, she has just about everything that, your entire afternoon boiled into one patient. She is ocular hypertensive, not extreme, right? Average IOPs range from 21 to 24. She also is a significant steroid responder. So as we've been managing different forms of her dry eye disease, we have seen sometimes when her IOP fluctuates quite a bit higher. We'll look at the structural testing in a minute, and I'll explain why we had tried different medications. You can see just about every different type of hypotensive medication we have tried on this individual. It's distinctly missing Ropressa and Rocklatan, but every single time we would start a drop, within about 8 seconds, it would light her up. It's like one of those, you dispense a sample, you cross your fingers. The next day, the office says, I have a voicemail from this individual already that first night saying I can't tolerate this drop. So she wouldn't do it. I'm gonna talk close to Dr. Lighthizer's heart about SLT. I know that he loves the SLT, and the first thing he's thinking is, why have you not done SLT? Well, the general anxiety disorder, we've talked about it every single time that we've tried to start a medication, and she just keeps shutting us down on it. So we'll go to the next slide.
If this isn't an argument for SLT, I'm like, holy smokes, look at that medication profile.
I know. You're so don't come through the screen at me just yet. I promise I'm on your side. Yeah. These are her fundus photos. Really not tremendous, remarkable findings here. The optic nerve, a little bit zoomed out, but nothing that jumps out at you in terms of tremendous cupping or pallor or anything looks abnormal. Again, I would classify her as ocular hypertensive, not specific glaucoma. Next slide. This is from visual field test. This is May of 2024. This is right eye. Again, as normal as it gets, VFI 100%. accurate reliability, no visual field defects. This is pre-parametric. Left eye visual field, next slide. Basically same thing. I'm not going to 4-alarm fire for the 99% VFI, and again, no nasal steps, no early defects. Why did I try to push the medication so much? We'll go to the next slide. This was her OCT in November 2023. In general, not too bad, but you can see on that right eye, she has a superior wedge defect. I'm going to trademark a term here officially. I am a wedge. My wife and I both, we are wedge groupies. What that means is if we go to a restaurant anywhere in the country, any meal, any time of day, and there's a wedge salad on it, my wife has to get it, right? She has to. She's not physically capable of passing it up. That makes her a wedge groupie. I'm a wedge groupie because if I see a wedge defect on an OCT, I have to address it, right? I can't look past it. Dr. Lighthizer, are you a wedge groupie as well? Or
potato wedges or something like that,
Okay.
Yeah, but okay, back to the OCT. Yes, I'm also a wedge groupie.
Okay, good. All right, thank you. So anyway, this is why I've continually said, look, there's some structural changes here. We have to, you're too young, right? Pressure's too high, too risky. We've got to treat it. So next slide, we check to see if there is corresponding structural changes to the ganglion cell layer. Looks perfect. Still 2023. Next slide, repeat the OCT of the nerve. Again, still fairly nonspecific, but we still have that wedge defect superior in the right eye. I'm still wearing my wedge groupie badge. I have to continue to try to monitor this, treat this. Same time frame. Next slide is the GCC for 2024. Again, no structural changes on the ganglion cell complex, just on the nerve fiber layer. Next slide. So we started utilizing the PHNR protocol for her to gather functional information on the ganglion cell layer as well. This is her first PHNR ERG that we performed in May of 2024. And this looks a little bit different than the DR protocol ERG. It actually teases out the waveforms. So it's giving us speed and strength, latency and amplitude in 3 different areas. It's going to give us that first little dip downward is the photoreceptor layer. We call that the A wave. The next large peak is the B wave. That's actually the bipolar cells or the communicating cells. And then the last tail of it is the ganglion cell layer. And we're actually able to tease out speed and strength across all of those different layers. That's why I said earlier, this is my favorite test. It gives such a phenomenal amount of information about where we can localize that stress. But for the purpose of this talk, basically, first test functionally PHNR was normal in both eyes. Now, we're watching her every 6 months because she does have the wedge defect and ocular hypertension coexisting. If we go to the next slide, subsequent ERG, just in December 2024, if you can see down on the right eye, the latency has increased significantly, actually to the tune of about 60 milliseconds in that right eye. So we're not only seeing functional stress on the ganglion cell layer, right? We're demonstrating stress with progression over a 6-month period of time. And so this doesn't necessarily move the needle for me so much because I had already decided that she needed treatment, right? I've been trying to have her sign up for referral for an SLT, accept that referral, see one of our specialists, or start her on medication, and she just wouldn't go. But for me to be able to go one step further and say, look, it's not just us saying your visual field's fine, right? And she's a highly educated patient. She always wanted to know, what did her visual field look like? What's my visual field look like? And she had convinced herself that if my visual field is fine, I'm okay not doing anything. But now we could give her that information and say, look, it's not fine. It's truly not fine. We are seeing progression of retinal stress in the layer of the retina that is consistent with glaucomatous damage. And at that point, she did agree for the SLT. She received the SLT and she's doing fantastic. And again, I know Dr. Lighthizer is going to say, don't you know, in the light study, the earlier the better. Don't you know that? And yes, I do, sir. But I tried. I promise. Yep. I tried. And finally, we won. Yeah.
Yep. Good win. Good win.
Yeah. So again, just really added that fundamental layer of functional testing that was the key to us in this case, not just for confirmation of what we were seeing anatomically, but also increase the value of our conversations and our influence in terms of compliance with treatment, compliance with recommendations, compliance with referrals. Again, this is really going to help this patient long-term based on what this test was able to provide for us.
All right, so I think this might be the last slide of our structure and function. We've hit this again and again and again. Earlier detection, following for progression, like Dr. Grant just outlined in that glaucoma suspect ocular hypertension patient, and then seeing improvement as well. So as we saw in the case that I showed you in that diabetic retinopathy patient, that the DR score went from 24.4 back to 21. So demonstrating improvement, that is really a win for these patients. So looking at structure and function, don't think of this as, okay, I've got my picture and then ERG needs to fit in and it needs to change everything. No, just loop it right in there. It's one of your tests, and you use them all together, all equally, to make the decisions together. And sometimes when you add up 5 different tests, I pull this one out because I believe the other 4. And ERG's in there. And it's other times, all right, I'm going to pull this one out. Use this together, and it makes you a better diagnostician when you have all this data.